We have now from Kiel University, Dr. Mohammed Saad, Dr. Dirk Frank. Mohammed, do you hear us? Yes.
Do you hear us, Dr. Amr, right now?
Yes, we hear you now. Welcome,
Yes.
Mohammed, for our meeting.
There was a small technical problem.
Yeah.
Do you hear Dr.
Can you hear
Frank?
me as well?
Yes.
Yeah, Dr. Frank,
So
welcome.
can you hear me as well?
Yeah.
Okay, welcome. No, we're
now.
very sorry. We're very sorry that we were muted. So,
Yeah.
welcome to Kiel. So I will hand over to Mohamed Saad.
Thank you, Dr. Amr, for the invitation. Thank you for the organizing committee. We are happy to be with you today from Kiel, from the CAT lab, from the hybrid lab. We have a case for TAVI, transfemoral TAVI. We will implant a Sapien valve. Dr. Amr, can you show the presentation?
Yes. Please open the presentation. Isra. Open the presentation.
I'll introduce the team till you open the presentation.
Okay, now please introduce
we
the
have
team.
on table Professor Frank Dirk. He's the head of our department. Mohammed Saad. Dr. Panholzer is the cardiac surgeon. He's on the table with every case that we do. We have our personal
Crimp nurse.
sorry?
Crimp nurse.
Crimp nurse, exactly.
Yes.
Who will crimp the valve. We have Christoph, Lewis, and we have our heroes from the anesthesia team in behind. We have already punctured. We do our puncture ultrasound guided. Do you have the presentation now?
Yeah,
open?
we are ready now. They're on the screen.
Very good. We have 78-year-old lady. She has severe aortic valve stenosis, has atrial fibrillation on anticoagulants. The mean gradient on the valve was about 41 millimeter mercury.
Yes.
Next, the ECG was a small, narrow complex ECG. She don't have any bundle branch block.
Yeah.
If you go further with the CT, you will
Yes,
see
we are
the
now
anatomy
with
of
the
valve.
CT, yeah.
It's not heavily calcified valve with minor calcification. However, the opening area of the valve was about 0.6 millimeter. If you go further, there is no LVOT calcification, and the vascular access is very suitable for transfemoral TAVI.
Okay. And this is a femoral, iliac and femoral axis. This is good.
Exactly.
Okay.
So maybe I can add something. So what we're doing here, we do a very minimalist approach. Nevertheless, we are here with a surgeon, with the colleagues from anesthesiology, but the patient is still awake. So we just have local anesthesia. We have done, as Mohamed already mentioned, the puncture with ultrasound guided access, and we will now continue with the vascular closure systems. We're typically using 2 proglides, and if you don't mind, we would directly head into the case, and Mohamed Saad is going to comment on it.
Yeah. Okay.
Very nice. You see our hands?
Yeah. Now we see your hands. Please zoom in. Osman, zoom in. Okay. Can you see
try to make
between
some place
you
for the
and
camera.
Mohammed, because we need to open the space between Frank and Saad. Okay. Now we
Like
see the femoral. Yes. Yes. Okay.
This is the first proglide. As you see, we go deep to the in the vessel until we have some flow from the sideway of the proglide. You have to be sure that you are well on the vessel wall.
Rotate the focus to the other side. Yes. On the other side. Okay.
So this is the first one, and we have put it in on 10 o'clock, and we will place the second one at 2 o'clock. Okay. So that we have a certain angle between the 2 proglides.
Mohammed Saad covering his hands. Either go a little back
I'll try to be on the
or to the right. Yes, this is good. Yeah, in between you. So we need to focus between both hands. Yes. Now we are.
You see, now we have turned for the second proglide the angle to about 2 o'clock.
Yes. Okay.
The first one was at 12 o'clock.
10 o'clock. Yeah.
Yes.
After that, we are going to put an 8 French sheath.
As a placeholder. It's just
Yes.
actually an 8 French
Can you turn
placeholder
off the
sheet.
light?
So you are preparing one ProGlide now and the other one?
No, 2. This
It's
is
already
the
two
second
in.
one.
I know. We
2
need.
ProGlides are in.
Okay. Cannot see the groin. Okay. So you are putting now 8 French?
Yes, we did our puncture ultrasound guided, and our aim not to do any radiation
focus,
until we
please.
have the 3 sheath in and the ProGlides in. Now we have for the accessory axis on the left side, the secondary femoral sheath, 6 French. As you see, this is the pacemaker cable.
Alles gut, Moment. Du kannst erzählen.
Migi.
We have used to use for a while wire pacing, but we were not that convinced with this method. That's why we returned again to the pacing with the cable.
So then there's the accessory pigtail catheter and the non-coronary cusp. We have used the bifemoral approach. We could have used also the radial, but in this case we preferred a bifemoral approach.
Okay,
So now we are changing in the stiff guide wire, given that we are treating a lady and have a rather normal to small sized ventricle. We will aim to use
Please zoom on the
Safari
screen.
extra
Zoom
small
on
guide
the
wire.
screen. The screen. Okay, this is good.
We use the Safari for putting
Go to
Pacemaker
the
testen,
screen.
bitte.
Yes.
the E-sheath.
Just here. No, not more.
We
yes.
don't
Okay.
use an extra wire for the E-sheath. We use the Safari to change for the E-sheath, and after that we will use the same wire for implantation of the valve.
Okay.
In the meantime, we have put in the pacemaker, which is being tested right now, as you might see in the ECG recording on the monitor.
Yeah. We look good. The hemodynamics are okay.
Bist fertig?
Dr. Mohammed, I have 2 questions for you. If you
Go ahead.
Okay.
Yes.
I want to ask about the coronary artery management. You have a big ramus branch with proximal tight lesion. So what you plan for
Yes.
dealing with this coronary artery?
It was done. It was done.
In the same
yeah.
session or previous
The
session?
problem that I don't have the presentation in front of me. That's why I couldn't comment on this. There
we
was
saw
a
it.
lesion in the. Yes, and it was done. Actually, the patient was referred to us from a peripheral hospital where the PCI was done there. But this is even our strategy
Erst ein
to
bisschen gegen.
to do the PCI
Nee, ein bisschen runterfahren.
before
die Anlage.
doing TAVI. Only for the.
Die Anlage runterfahren.
So
Not in the same session.
not in the same session.
37 bitte.
Okay, and the other question about the choosing of the type of valve. Why 7-3, not core valve? You have a special
The
indication
patient is
for such
suitable
a
for
valve?
both.
Yes.
Yes, we go more for volutes as primary valve for patients who are requiring small interannular valves. For example, the patients who are requiring Sapien 20 or 23 millimeter, we use mainly evolute for such patients. This patient will need a Sapien 26 millimeter, which is not that small, and the hemodynamics should be comparable to the evolute for in this case.
So as you have seen, I've just put in the E-sheath in. Went smoothly.
Yeah.
Auf 27.
From the CT, that the calcium is not so too much in the.
There is no
CT.
eccentric calcification.
Yeah.
There is equal distribution of the calcium in the all leaflets. There is
Yeah.
no LVOT calcification. That's why it was our choice for the Sapien. There is another important point as well, is the age of the patient. Here in Germany, 78-year-old is not that old, and I think the surgeon is on the table right now. He was going to do an operation for here, but we have refused this.
Was
Yeah.
ist die kalkulierte
Sorry for
Ambulation?
that, because I
So
know
we-
that this is what the great things that is a very important team.
That's why we are considering maybe valve in the future. That's why the decision for Sapien as well.
Yeah, this is good.
Angulation.
So this is one of the important indications when you use valve in valve. You know, the younger. younger patients, and we're using
Yes,
so
if you
use
have the
first
first
Sapien,
valve
then
as
She's
an
not that
intra-annular
young.
valve.
She's 79.
73.
73. Okay.
78, but as I told you, in Germany, this is not an old patient here in Germany.
Yes,
Zehner
yes,
Angio,
yes.
bitte.
Looks like
Until
us,
80,
the
till
same
80
age.
years old,
It's
Yes.
like us now in
patient
the.
can be safely operated here. Surgeon is laughing.
So we are now preparing the crossing of the valve.
Yeah.
So we have pre-calculated a potential 3-cusp view. Zehner Angio, bitte. 10.
Yes. So this is a cusp overlap.
No,
No,
Okay.
we will implant the valve in the 3-cusp view. This is not
Yeah.
the 3-cusp view, it's just LO for crossing of the
Yeah,
valve.
yeah, yeah.
But
Okay.
we try to implant our implantation method here in Kiel for the self-expandable valve with the 3-cusp view, for the balloon expandable valve with the self-expandable cusp overlap view, for the balloon expandable valve like this case in the 3-cusp view.
Okay.
please go to
And
the
we will adjust the view with according to what's called line of lucency. We'll show it right now to you.
Kannst du
This
Three
is a
Cusp machen,
tromo
bitte?
straight.
Brauchst du
Well,
immer
die
nur-
Ebene, die erste Ebene.
No, this is a straight soft tip steel wire,
Ah, okay.
LO8 cranial 4.
which is the standard we use.
Yeah, yeah.
This
Yes,
should be the
دكتور
3-cusp view.
دكتور سعد hello I'm محمد فوزي ازيك I'm
ازيك
asking
محمد؟
about it's preferable to use
Yeah,
multi-purpose
great.
cassette
Cross.
27,
دكتور سعد
27 FD.
Sorry,
دكتور محمد سعد how are you
أنا سامعك محمد. I hear you.
if you after multiple tries to pass a wire multi-purpose can help a lot more than ambulance or not it's not your usual practice.
No, multipurpose shouldn't be the first option in this case. Our way to cross the valve to use the amplets left 1 or 2 or the Jatkin right in case of the horizontal aorta. But multi-purpose, we don't have a big experience at least with it. I don't think if too many operators use multi-purpose for crossing the valve or not. But the most catheter that's used is the amplets left 1 or 2, and for the horizontal aorta is the Jatkin right.
Yes.
So
So
we have now exchanged the AL1 for a soft, just simple J-tip wire. And we are now exchanging again for a 6 French pigtail catheter to make sure that we have a very atraumatic placement of the stiff wire in the left ventricle
okay.
without causing any perforations or something, which is the standard here. As you can see, it's a little bit of a horizontal
Yeah, great. This is the big tail.
anatomy, but not too bad.
Yeah. Also, the direction of the big tail is the curve is up to avoid to be pushed directly to the LV apex.
I think another indication for the Sapien 3 valve is a little bit horizontal aorta, maybe more suitable for this type of valve than the other self-expanded
Absolutely.
one.
Fully agree. Yes.
Yes. And we are
I fully agree. So in this case, we are very happy to have the Sapien available because of this kind of anatomy.
Yeah.
I fully agree with you.
yes.
So now atraumatic placement of the extra small, and it's still big, as you can see, safari wire, and we are, I think, happy with that. This is already the proposed implantation view, so we'll have a little bit of an angio, just 10 milliliters, 10 milliliter angio bitte,
Yeah.
just to make sure that we are in the right plane. So patient is perfectly stable.
You
Great.
already
Just
determined
on
the
local
co-planar
anesthesia,
view
I think the
CT
view is
or,
very good.
And also the
Sorry?
position of the guy, the aortic root is already is very good. The big tail.
I didn't hear the question.
The co-planar view is already
I think it was just a
determined
comment.
by
yeah.
CT or just by tilting the table during angiography.
So no, we typically pre-calculate the plane from the CT scan using the three-dimensional analysis. This is the calculated angulation, and I think it's very fine. So we are seeing all three curves, which is a nice view. And as Mohamed Saad already mentioned, we will adjust it in a minor fashion just to have this line of translucency in the valve frame in a second for the implantation. So we are happy. Genau.
And what about the need for pre-dilatation? You will do pre-dilatation or just direct putting for
We
the
do
valve?
pre-dilatation if the valve is heavily calcified, and if you and especially if you are going to implant a self-expandable valve. For the balloon expandable valve, when the valve is not heavily calcified and we have the feeling that could go without any problem through the annulus, we don't try to do any pre-dilatation.
So we are now pulling back the balloon catheter within the valve frame, adjusting the balloon within the frame. Typically, and that's also the instructions for use, we now must have a little bit of a cranial angulation to make sure that it's fine. It is fine. So we go back to our implant view and continue. What we typically do here in Kiel, that we like a quick move across the aortic arch. So I don't like spending too much time in the aortic arch. It doesn't make any sense to me. So what I do is I angulate, cross quickly the aortic arch, go into the valve, use the momentum, as you can see here, and we are within the valve. Patient is still hemodynamically perfectly stable. So the pigtail is a little bit folded, which is typical when you cross the valve. So we will adjust the pigtail in a second. Here we are. And remove the pusher back to the middle marker, to the Angio. Bitte die Schleuse halten. Quittieren bitte. Okay, so here we are. So now we have a field diameter of 22. We have the point on the level we want to implant. Das war richtig. Lewis line of translucency. So Mohamed Saad, now, as you can see, use the line of translucency technique to make sure that we are on the right plane. I'm actually happy. I like to implant the valve rather high into the aorta. And now we would directly continue because otherwise we will end up with an unstable patient. So Pacer 180 ready.
You will pace? Or?
Yes. Pacer on.
180.
180.
I think that sounds why.
Okay.
Okay.
Angio.
Pigtail.
Okay, go. Implant. Wow, nice.
Yes.
Okay, 4, 5 off. Pacer off.
I think we have no parallax, which means that we have the right view.
So, and I like to remove the balloon immediately, go back into the ascending aorta. Rad vor.
Flex. Ja, okay.
Ist raus. Mir ist der Flex immer raus. Okay, good. So we're removing it. So blood pressure is recovering, as you see. We are at 73/33. We're leaving in the wire, removing the delivery system, and now we'll exchange the stiff wire for pigtail catheter. We will directly, so we're absolutely sure that the valve is large enough because we had an area of 458 square millimeters, and we have used a 26 Sapien, which is rather big for this kind of anatomy. So I think we will definitely have no issues with the PVL, no significant issues. So now we're exchanging the stiff wire for pigtail, and we'll directly continue with hemodynamic measurements.
Great.
So you will have the pressure recordings in a second on the monitor. So here we go.
Great.
I think we have to do something with the pressure. Okay, okay.
So we have, could you please zero again? So it seems to be that the zero line has shifted a bit.
Yes.
Bitte nullen.
Can you focus on the hemodynamics, please? Yes, sir. Eventi have also a very good effort that help
think
us
the pressure
also
is
with
recovering
other company
slowly.
in Germany
Einmal
that
Nullen,
you
bitte.
can focus on these great hands, and then you can see the hemodynamics, and they do everything. The very good cooperation between the companies.
Ja, bitte
and-
Nullen.
Yeah, so it's very nice to see when we are using the camera. They have only the camera, and we move from here, and not from Germany. So this is a good. Thank you, Eventi, for this. And also,
You can see
thank
whatever
to
you
the-
want. I think this is a great option.
Yeah, the problem is we can leave you and go back to the back stage. it's
Beide
it's-
Nullen.
it's
Nullen.
fantastic.
Nullen. Ihr müsst nicht beide weg. Ja.
Also, Tigas.
Okay, so we
do
had a
lot
little
of
bit
things.
issues with the hemodynamics. You will have again a hemodynamic recording in 10 seconds, and as you will see there, we will have what we call the yellow sign. This
Yeah.
is the perfect result when you have the red and the green curve lying directly over each other. That's what we call the yellow sign. You will see it in a second. So
Yeah,
we're
we
absolutely
can.
convinced that we have nice hemodynamics.
Why the hemodynamics the pressure is not seen only the.
It will appear right
We
now.
just zeroed it
Okay.
because it was not as accurate as we want. We want very accurate hemodynamics. Here you can see, here we are, yellow sign. You see it? Perfect result.
No gradient.
No
The systolic
gradient
pressure is
and
50.
bitte Rückzug.
Okay.
And now we will do the classic pullback to make sure that there is no failure in the recording. Classic pullback. So we will record the pullback from the left ventricle into the ascending aorta, and then end with an angio. So this is the pullback. You've seen it. It's perfect.
Yeah.
So it's yellow. So very accurate hemodynamics. That's why we zeroed.
Yeah, it's fantastic result.
And-
There is nearly
Now,
no difference.
final angio.
Yeah, please. So,
20er Angio bitte. Zwanziger Angio bitte.
Angio.
Und los. So here's the result. I think it's almost
Excellent.
perfect. It's 25 to 27.
Yes.
very nice result, Dr. Frank, and also Saad. Thank you for this elegant demonstration of.
It's a very straightforward,
Yeah,
minimal invasive,
it looks easier than
really
simple
streamlined
PCI.
case.
Very few amount of
And the
contrast as
patient is
well,
going to be
because-
discharged. Patient is going to be discharged on Sunday. We have a narrow
Yeah.
QRS complex, as you can see on the monitor.
Yeah,
So
yeah.
this is how we do it in Kiel.
Yes. Thank you. Thank you. Thank you. Thank you. And we are really happy that you accept
Thank you,
our
Dr. Amr.
invitation to give us a very good demonstration how to do TAVI easy step by step. And thank you, Mohammed Saad. Thank you, Frank, and for this
Thank you, Dr. Amr.
great demonstration. All the team, thank you. We are very happy. We have a lot of attendees here. Thank you very much. See you in Cairo
Goodbye.
next meeting. Thank you.